So our brain is just like a computer that's receiving a signal, and then it's basically where we realize what's actually happening. And it's subjective. So it's not an objective experience. So when we define what subjective means, it means that it's up for interpretation. And so if you have a pain behind your eye, it doesn't mean that your eye has a problem. But what happens is you get an X-ray, an MRI, a CT scan, maybe it's in the ER, and they're looking for life-threatening things. But this isn't a life-threatening condition. It's just a really bad pain that's likely coming from your neck, jaw, shoulders. And so when they do these images, they don't find anything that would make sense for you to have this pain.
Welcome to Beyond the Pain, the podcast that explores what it really takes to break free from chronic pain and reclaim your life. I'm your host, Leigh Brandon, and someone who's spent over 2 decades helping people get to the root cause of pain that no one else could explain. Whether you're dealing with long-term back issues, joint pain, nerve discomfort, or mysterious symptoms that just won't go away, this show is here to help you go deeper. Because beyond the pain, there's clarity, strength, and power waiting for you. Each week, we'll uncover the physical, emotional, biochemical, and energetic causes of pain and how to transform them. Let's dive deep into this week's episode. When you experience a migraine or persistent headache, it's natural to assume that the problem must be coming from inside your head. But what if the pain behind your eyes, across your temple, or throughout your head is actually coming from your neck? In this episode of Beyond the Pain, I'm speaking with Dr Jono Taves, a physical therapist, headache specialist, and founder of Novera Headache Center. Jono explains how neck dysfunction can contribute to migraines and chronic headaches, why this connection is frequently overlooked, and how previous injuries, posture, and stress may influence symptoms. We also discuss how targeted physical therapy and lifestyle changes may help reduce headache frequency and severity. So if you experience recurring migraines or headaches, particularly following a sports injury, concussion, or whiplash, this conversation may give you a different way of understanding your symptoms. Here's my conversation with Dr. Jono Taves. Jono, welcome to Beyond the Pain. Great to have you on the show.
Yeah, happy to be here, Lee. Thanks for having me.
Yeah, looking forward to this. So before we explore migraines and chronic headaches in more detail, what I'd like to do, I always like to ask my guests if they would share their own journey and what led you to specialize in helping people with persistent head, neck, jaw, and facial pain.
Yeah, absolutely. So I graduated as a doctor of physical therapy from the Mayo Clinic in Minnesota. And so the Mayo Clinic is a unique spot because I had access to world-class physicians and healthcare providers that were treating all sorts of complicated things and on the cutting edge of what our healthcare system could do. The unique thing there is like the Mayo Clinic and that program provided the foundation, but it didn't necessarily prepare me for treating headaches and migraines. I got introduced to sort of elements of this treatment with a few other physical therapists that were working on the neck in particular. So there was someone who came to our Mayo class and taught a course on the jaw and the upper neck and the biomechanics of it, so things like that. And then I started to work. When I graduated, I worked initially in a practice that was pretty hands-on. So we'd see like shoulders, back, all the classic physical therapy stuff that you think of. But it was all very like manual therapy focused, so meaning hands-on. And there I got experience in treating the neck. So I was able to apply what I had learned. And a lot of times I was treating headaches, neck pain, more so in that category. And then what happened was within probably 6 months of graduating, I saw my first migraine patient. And this is someone who initially I thought like, well, a migraine is a neurological problem. And so I can work on your neck, but that's something the neurologist needs to take care of. And they said, well, I've seen multiple neurologists, taken all the meds, and nothing has helped. And so what happened was I worked on her neck and her migraines went away. And it was this realization of, okay, if I did this with you, there's probably more people out there that have been misdiagnosed and need attention to their neck. And I just kept finding these people with migraines. And so that first year there were probably a few dozen, and it was like all of them got better. I mean, it was like
Mm.
100% of people that I worked on had debilitating migraines for decades. Nothing had helped. They were feeling hopeless. I work on their neck, they get better. And so I dug into what the research showed and how these neurologists were using their clinical experience and research to guide their practice. And essentially, it was all symptom based. So they were just managing symptoms with meds. And there was
Mm.
no conversation about root cause or like what was actually causing the pain signal. And it was such a clear connection to the neck being able to refer pain that I said, okay, well, I'm going to spend my career solving this problem.
Ah, interesting. So how long have you been graduated?
10 years.
Okay, cool. So I guess it was something because oftentimes, you know, there are people in our field and they get into what they do because of their own story. They went through their own challenge and then they went and found the solution themselves and they thought, well, I want to help people overcome the same thing that I did using the same techniques that I did. But I think you're similar to me, and that's not your story. Your story just came about from, you know, you went and studied, you started practicing, and then you just started to see these people coming to you, and then you realized, oh, I can help these people that have been to many other people previously, in some instances, didn't get any better, and in some instances actually got worse. And what you was finding is that you was actually able to help those people. And I'm sure you'll agree with me, when that happens, it's really satisfying that you're able to
Oh,
help someone and, you know, able to get their life back. I mean, I've not worked with many people with headaches and migraines, but I do know my mum suffered from migraines a lot as a kid. And some days my mum would just be in her bedroom, curtains closed, and we just knew, don't go in her bedroom, don't disturb her, because she was just no good to anybody. So I know how debilitating that is. And, you know, I imagine for some, I mean, my mums were quite sporadic. She might have like 4 a year that were like
mhm,
really bad. And she
right.
was just couldn't do anything. And, but, you know, I'm sure you've got some examples, but, you know, I'm sure there are people who have migraines a lot more frequently than my mum did. And you kind of wonder, how do they even get through life if indeed they do at all?
Right. Oh yeah, yeah, and you're exactly right that the impact that I saw that this form of treatment could have on someone's life is really the main thing that's motivated me. And that's positioned with, I mean, as you're saying, the debilitating nature of migraines, it's the second most debilitating, what they call disease. I don't call it a disease, but um, if we're going to use that label, yeah, it's one of the most debilitating things on planet Earth. And so it puts people in bed and it impacts their careers, it impacts their time with family and friends and their social life. And so people feel very stuck and relying on medication and fearful. Even when they don't have a migraine, they're just always worried about when the next one's going to hit. And it was just amazing to me as a physical therapist. You know, you think of oftentimes physical therapy um, is, you know, post surgical rehab and you're just like stretching knees and stuff. Not to minimize that type of care because it's important, but when you can take someone that's been through our healthcare system and worked with multiple neurologists and found little to no relief, and then you can change their life as a provider, that's like, wow, I need to lean into that because there's a lot of value there. And it makes it very rewarding and enjoyable to be a provider, even though it's not easy. But over the years, we've come up with a framework that makes sense. And so we have a lot of confidence in something that's challenging.
Mm. Yeah, and I guess there's probably a number of people you've worked with that they think you're a magician or an angel or something along those lines, because I often
Sure.
hear words
Yeah.
like that.
Oh, absolutely. Yeah. Yeah. And really, yeah. And that probably comes from the fact that, um, yeah, Leigh, and you're working with the fundamentals of the human body and just sort of aligning people with what health should look like, which is mind blowing in a sense because our healthcare system does something completely different, but it really shouldn't be.
Mm, absolutely. So why is it, in your opinion, that migraines and chronic headaches are so often misunderstood and in many cases mismanaged?
Yeah. So the migraine experience is very complicated. So meaning it's unique to the individual in the sense where everyone has their own presentation of symptoms, and so the symptoms themselves are tricky because of two things. The brain, when it experiences pain, can confuse both the location and then also the type of sensory input. So our brain is just like a computer that's receiving a signal, and then it's basically where we realize what's actually happening, and it's subjective. So it's not an objective experience. So when we define what subjective means, it means that it's up for interpretation. And so if you have a pain behind your eye, it doesn't mean that your eye has a problem. And that's hard for people and doctors and our medical system to understand. And so referred pain and even the brain interpreting a signal as something other than pain itself is very confusing. And so when it comes to like the patient itself understanding like what is wrong with me, it's hard for the patient to understand, and it's also hard for the provider to understand. And so what happens when someone has like a one-sided stabbing pain behind their eye or in their temple, or it starts in the back of the head and wraps up and around, is we intuitively think that something's wrong with the head or the brain. And so what we do is you go to your healthcare provider, and because the pain's so severe, they take it seriously, and that's not inappropriate. That's accurate. Like a severe pain should be taken seriously. But what happens is you get an X-ray, an MRI, a CT scan, maybe it's in the ER, and they're looking for life-threatening things. But this isn't a life-threatening condition. It's just a really bad pain that's likely coming from your neck, jaw, shoulders. And so when they do these images, they don't find anything that would make sense for you to have this pain. Like your brain is fine, your eye is fine. And so they say, well, there's nothing that would like cause this. And then you're just led down a road of meds. And so the problem is that they're not trained in understanding the referral pattern from the neck. And so when we think about things that it can objectively be wrong that send pain to the brain, and then the brain subjectively gets the information incorrect and thinks it's your eye, the neck is one of the most likely scenarios, and the neck is very mobile, meaning the neck has the highest risk of developing an injury, whether that's just like stress over time or some sort of trauma in your life, like a car accident, something like that. And so a lot of people, kind of like the teeth need to be brushed and flossed in order to prevent cavities, a lot of people are just unaware of the amount of stress they're placing through their neck, and then they develop a neck problem that then sends pain into their head. But we're not checking the neck as it relates to movement, meaning rotation, nodding. Now, most of our patients can do those things. It's just specifically what happens in the upper neck, which is where we get most of our mobility, and the area that's going to send pain into the head. And so because of these dynamics of pain kind of confusing us, okay, it's behind my eye, let's do an MRI, it feels very severe, like I'm dying. So let's check for the things that are going to, like kill me essentially. And when those things are cleared, and then we just go down this road of symptom management, and essentially what our healthcare system has done has used this like cyclical reasoning of like, okay, medication works, so therefore this is a brain problem and a chemical problem of like serotonin levels, things like that. When really that's just, you're looking at the brain's response to pain itself, you're not finding the source. And the most common underlying source is an actual neck issue.
Yeah, I mean, the one thing I was thinking as you were speaking there is the fact that pain doesn't always mean tissue damage, right?
Yeah,
particularly
absolutely.
in the bit that's hurting. But I completely understand why someone might think, oh, if there's pain in my head, there must be something wrong with something in my head.
Right.
That's
Right.
very understandable. But I think for me, and this is certainly very much part of the Czech philosophy, is that when you're in pain, particularly persistent chronic pain, the question is not how do I get rid of the pain? The question is, what is this trying to tell me? What potentially is this trying to protect me from? Because that's what pain signals are, right? They're danger warning signals.
Right. Exactly.
Right? If you step on something sharp, you want pain because that's going to prevent you from sticking whatever this sharp thing is straight through your foot, right? Or, if you've got your hand on a hot stove, you want to feel it, because otherwise your hand is going to melt away into nothing, right?
Exactly.
So pain is a blessing, right? There's a great
Yeah.
book called The Gift of Pain, right? And if we didn't have pain, those examples I've just mentioned, you would go trod on anything sharp, you would completely obliterate your foot. If you didn't know that your hand was on a hot stove, you would completely destroy your hand. So pain is there to help us. But the question is, what is it trying to protect us from, or what is it trying to tell us? Rather than how do we get rid of it? Right. And yes,
right.
pain is unpleasant, but it's unpleasant for a reason, right? So what I'd be quite interested to get your opinion on is there a difference between migraines and headaches? And if so, what's the difference?
Yeah. So this is a really good question. I'll probably give more context than potentially what's needed, but I'll give context because I feel like it's helpful in the answer. When I'm trying to answer this question, you have to understand that the term migraine and then headache to some extent but the term migraine in particular is a diagnosis that comes out of a model that I don't particularly ascribe to. Okay. So what that means is when you go see your primary care doctor or your neurologist, you will very likely, with any sort of head or facial pain, you'll receive a diagnosis that's based on your symptoms. So again, those subjective symptoms you're sharing with that doctor, like I have a debilitating eye pain and it's accompanied by light and sound sensitivity and I get nauseous and there's an aura or something like that. Then they'll say, okay, that's a migraine. So now you have the diagnosis of migraine, and that migraine diagnosis is essentially a way to communicate to other providers in our healthcare system that you fit into a category that requires medication. And so when we're looking at interaction with our healthcare the environment, the migraine diagnosis has some risk to it because you're communicating there's no underlying cause. It's classified as what's called a primary headache. And a primary headache is basically saying like there's nothing else to look for. The pain itself just needs to be managed. And so when we're talking about dynamics where pain is a feature of our body and we need to figure out what's causing the pain, migraine itself is put into a category where like our healthcare system has basically thrown up their hands and said, well, it's a primary headache, there's nothing else to look for, so stop looking. And I actually have people like get upset that like we're finding something that's fixable. She's like, no, it's a primary headache, like you can't find the underlying thing. And so it just that's the risk in the migraine diagnosis. The benefit in the migraine diagnosis is that it gives people, the individual that's suffering with this, a way to communicate to those in their life that they're going through something that's very challenging, that it's debilitating, that, hey, I can't go to work today because I have a migraine. And having language like that is important because if you just said, well, I have a headache, that could mean a whole bunch of different things. And because lots of people have headaches and they just push through them and it's no big deal. And so there's pros and cons. A headache itself. Now, okay, going back to migraine, the diagnosis itself is going to be based off of a debilitating pain. Usually it's one-sided, and it'll be accompanied by lights and sound sensitivity, maybe nausea, and then sometimes there's an aura, which is like something that is before the pain itself, and oftentimes it's a visual disturbance, something like that. And so that's like the classic definition of a migraine, whereas a headache can be, so there's different types of like headache diagnoses. Like tension type headache is one of the most common, and that's sort of this band strap like presentation in the forehead that builds up throughout the day. The most common type, like if we're going to use the diagnosis within our healthcare system, it would be a cervicogenic headache. And so this is basically a headache that comes from the neck. That's what that means. And I've been doing this for 10 years and treated, our practice has had over 1,500 cases. And then a lot of those are specific migraine diagnoses, and we're treating the neck and their migraines get better. And so by default, that would mean we're treating cervicogenic headaches. And so when we're trying to understand like these diagnoses, like most people are just misdiagnosed, if I were to say it bluntly.
Mm.
But I also don't necessarily care so much about the diagnosis. I just want to talk to you and understand what your situation is. And once I get that information, then I'll know what to do. But the diagnosis itself, if you said, "Oh, can you treat migraine?" It's just like trying to talk a different language because I don't work in that world, if that makes sense.
Mm. Yeah, absolutely. Just going back to the question as to, why are many of these cases mismanaged? And you kind of touched on it, but I'm going to add a little bit on. And I'm just going to be honest. You called it a healthcare system. I think you're being polite calling it that. The system, let's call it, some people call it a sick care system.
Yeah.
Is run by corporations whose really their ultimate goal is to maximize profit. Right now, if you have a traumatic injury, if you have a life-threatening condition, they're definitely the people to go to. Right? Don't go to a homeopath if your leg's hanging off.
Right.
Okay?
Right. If you're dying.
Yeah. But my experience has been when you have a chronic condition, let's call it, they're able to make really good profits because there's a lot of repeat business. And whether that's pain meds or more appointments, more treatments, whatever it might be, they're not trained to get to the root cause of the problem.
Right.
And if they did get to the root cause of the problem, it's going to hurt their profits, which legally they're supposed to maximize, right? And they've got shareholders who are going to say, well, hang on a minute, you're not maximizing profits. So it's a bit of a merry-go-round once you get on that, right? And it's quite difficult to get off, particularly, you start on one, let's call it, a pain medication that may have side effects. But of course, there's another medication for that side effect, right? And then that creates another side effect. Oh, we've got another medication for that. And before you know it, there's a member of my family, they're on 18 medications a day.
Yeah.
Right?
Yeah.
And they're all toxic. They're all creating further imbalance in the body, right? But if you get straight to the root cause and you deal with it at that level, and we'll probably come on to talk about it as well, but if you can empower the person to play a role in their recovery, now all of a sudden they're not profitable. Right? So there's big financial interests into not achieving a good result. Let's just put it that way.
Yeah. Actually, so Peter Attia in his book Longevity, he had a really good insight. He kind of frames it as instead of lifespan, he has a health span chart. And so, but there's data to show that our healthcare system, or the system, has not actually improved quality of life at all. And so our quality of life still drops off at the same period of time. But what happens is we have what used to be we die is we live, but we're sick. Like we're just sick for a longer period of time. And so our healthcare system is really good at keeping people alive, but the quality of life is of no concern. And that's kind of what you're hitting at is like sick people that are alive for a long time are worth a lot of money. And that's why our healthcare system is so very bloated and makes a ton of money, because there's a lot of sick people that they're very good at keeping alive. And then, it's repeat business. Whereas health span, you ask different questions. You try to understand, like, why is this happening? And then if you can have a health span that's like you live into your 80s and 90s and you're actually functional and healthy and not relying on meds and you're physically able to do the things you want to do, that's a very different type of healthcare system, and the one that we should be working within.
Yeah. For me, it's all about quality of life and having choices, right? Because you can become a prisoner to your pain, right? If your pain is preventing you from doing the things that you want to do in life, if it's preventing you from making certain choices, you're no longer free, right? Freedom means you have choice. If having pain means, you can't socialize, or you can't play with your grandchildren, or you can't go to work, you're not free. You're a slave. You're a slave to the pain, right?
Right.
So for me, it's all about being able to do whatever you want to do whenever you want to do it, and having no limitations.
Right.
And if you've got a migraine, I mean, I don't know if I've ever had a migraine. I've had the odd bad headache in my life. But, if I was having those on a regular basis, my life would not be fun. And I certainly wouldn't be doing what I'm doing.
Yeah, absolutely. Absolutely.
So when someone's been living with recurring headaches or migraines for a long period of time, what are some of the most commonly overlooked root causes that you tend to see? If you've been living with chronic pain and feel as though you've tried everything, it may be because an important part of the picture has been overlooked. In my book, Beyond the Pain, I explore why persistent pain is not always explained by the place where it is felt. Structural and biomechanical factors matter, but so can nutrition, inflammation, sleep, stress, nervous system sensitivity, suppressed emotions, and the meaning your brain gives to what is happening. The book will help you look at your pain through a wider, whole-person lens and begin identifying the influences that may be keeping it going. You can find Beyond the Pain in paperback and ebook through the links in the show notes.
Yeah, well, this is a good segue into our three-spoke framework. And so some people might be thinking like, well, surely the neck isn't the only variable, and they would be correct. And so we have a three-spoke framework, and so there's three sort of buckets that we look at when we're evaluating and then educating someone or treating them going through a process. So the first bucket here is going to be the source of pain itself. And so something needs to send pain into the head. We don't ever take the assumption that like the brain is just manifesting this because it's like a chemical thing. We don't believe that. And it's because it's not like we don't find it to be true. Like I've yet to find the person, and we have people that fly in from all over the world to come see us. So like I don't think they're just hiding out there. But what's happening is there's something sending pain, and that's been overlooked, and it's usually the neck, the jaw, the shoulders, and it's a movement problem. So the way that the individual is moving is either restricted or dysfunctional. And so they're going through life and they're just carrying a lot of tension, even though they're able to do, they're still able to turn their head, reach up overhead, things like that. They just have pain associated with it, and that's a headache. And so understanding what's actually causing the pain is the first step. The second thing that we look at is what we call developmental barriers. And these are things, one of the biggest things in this category would be like someone's airway and their quality of sleep. And the reason we call them developmental barriers is because someone's sleep quality and airway is impacted to a great extent by their upbringing in their childhood. So when they were an infant, were they breastfed and were they given solid foods? Did their upper palate get to like expand and widen because their tongue was swallowing and pressing up against the roof of their mouth properly? Because all of that in development is key for this like widening of our upper palate, and then our jaw will come forward. And then the upper palate widening is actually going to allow our nasal passage to open up. And then we can breathe through our nose. And breathing through our nose is how we should breathe 100% of the time. I mean, I guess if you're like, moderate to higher intensity exercise, things like that. But if your mouth is open, you are breathing through your mouth and you're doing it wrong. And so mouth breathing limits our body's ability to get into the rest and digest, that, the parasympathetic system. And so what we want to do is breathe through our nose. It produces nitric oxide and gets us into deeper rest. And so the sleep quality of someone can be impacted if all of that developmentally didn't happen. And then what happens is not only is their sleep quality reduced, which has impacts on their body's ability to recover and tolerate pain, but also it increases the amount of tension through their neck and jaw. Because if you're mouth breathing at night, your head's cocked back, and then you're trying to just keep your mouth open by like thrusting your jaw forward over and over because your tongue's probably falling back and blocking your airway. And then we get into like sleep apnea and stuff like that. And so we look for things like that basically developmentally you inherited from your mom and dad, or you inherited hypermobility or a long neck, or the predisposition for injury, or like developmentally your environment or lifestyle just didn't allow for this sort of stuff to develop properly. And so we want to find those things and address them. And then the third thing we look for is what we call the general health category. So everyone we work with, we want their general health to be as good as possible. So what does your diet look like? Are your hormones balanced? Are you stressed out all the time? These are things that impact your body's threshold for pain. And so if your threshold is super low because your body's dealing with inflammation, because your diet's all over the place and your gut health is all out of whack, that's an issue. And we find that those are very difficult scenarios to get people out of pain, even if we did all the best things for your neck. If you were just so inflamed, like it's going to be very challenging to get you out of migraine zone. And so both variables need to be addressed. And so that's the three spokes in our framework that we look at. And when we have all three, we have a more comprehensive approach to care. And so when someone's thinking through their own scenario and like, what would be a root cause reason for me to have these? We tell people, don't think of like, it's just that one food that's inflammatory, or it's just the barometric pressure changing, or it's just your hormones and the dramatic shifts every month. It's not just one thing. It's all three of these things, and everyone has a different degree of like which is most important to focus on, but don't ignore the other categories just for the one. So that's my best bit of like education and how to think through your own scenario.
Yeah, and that's really great for me to hear because, particularly with chronic conditions, I've found, and I've been working for 25 years now with people in pain, and with chronic conditions, it's very rarely one thing. It normally is a combination. It sounded to me like what you was describing was what's called central sensitization, where you've got multiple inputs into the nervous system and it becomes more sensitized. So then your pain threshold drops, and then you're more likely to experience pain. One thing that I talk about a lot in my most recent book, Beyond the Pain, is my theory that there are four main areas of causation of pain. One is structural. Now, you've already spoken about that, right? About the neck, the jaw, etc., referring pain to the head. Metabolic, you've spoken about nutrition. Nervous system regulation, you've spoken about that. And then the fourth one, which I think affects nervous system regulation, and that's emotional trauma.
Right. Absolutely.
And I think, in my experience, quite often, 2, 3, or 4 of those are involved in chronic conditions. So it's really good to hear that you're kind of on the same page as that, at least to a degree.
Oh, absolutely. Yeah, absolutely. And I think we as clinicians, and I'm very okay with having my expertise being in the like mechanical, I get the neck moving department. And so oftentimes we're leveraging the expertise of others, such as yourself, because I don't feel the need to be an expert in each of those areas. Meaning, if you have a significant airway issue, it's not me. If you have a significant gut health issue, it's not me. But what we do is we create a team of people that all have their lanes. But if any of those people, if I were to send someone to a provider and they'd say, well, it's not your neck, it's just your gut. I'd say, no, don't tell the patient that, because it's not true. And so sometimes we fall into like we pigeonhole and we say like, we're having success, and so this is the problem. And so what I've learned throughout my career is like, you can have your lane in your specialty, but like zoom out and understand the whole picture, because it's so important.
Absolutely. Yeah. And I've seen over the years when I've, worked in bigger facilities and you work with other people and you see they go on the latest course, and when they come back and everyone that walks through the door needs that
right
technique that they've just learned. Right. It's always made me smile when I see that happening, even though, obviously I'm not smiling for the client, but I just kind of smile and just think, here we go again. And then they'll go on another course in 6 months' time and they'll come back and that will be the only thing that they do for 6 months. So yeah, you've definitely got to have that helicopter view and be able to see it holistically. And again, it's great to hear that, you are referring to other people. And listen, I refer to other people. I've worked a lot over the years with a Nuka chiropractor. Unfortunately, she's not in the UK anymore, as far as I know. Biological dentists, Bates method practitioners.
Right.
Before I trained in it, I would refer to manual therapists. I've sometimes referred clients to Paul Chek. But I have picked up a lot of tools along the way as well. So I do work structurally and metabolically, nervous system regulation, and on the emotional side. But I still need that referral network, right?
Right.
Because if someone comes in and I see they've got a malocclusion, there's only so much I can do with my hands-on skills. The chances are I'm going to have to refer them to an orthodontist,
right,
to help realign the jaw. So yeah, again, that's really pleasing to hear that you're working in a similar way to myself. So in terms of the neck or the jaw, so you've already mentioned that the neck or the jaw can contribute to headaches and migraines and facial pain. But how, for the audience, can you explain how dysfunction in the neck or the jaw contribute to headaches, migraines and facial pain, and why these connections might be missed during a quote unquote conventional assessment?
Sure.
If your pain keeps returning, moves from one part of your body to another, or has failed to respond to the treatments you've tried, you may need someone to look beyond the painful area. In my consultations, I take a whole person approach, exploring the potential structural, nutritional, physiological, nervous system, lifestyle, and emotional influences contributing to your symptoms. The aim is not to simply suppress your pain. It is to help you uncover why your system may be producing it and create an individualized plan that helps you participate in your own recovery. If that sounds like the kind of support you've been looking for, you can find out more and schedule a discovery call using the consultation link in the show notes.
Yeah, so it all comes down to movement, and that's what physical therapists are trained to do, is understand movement problems. Most are unfamiliar with maybe even the biomechanics of the neck, like how the neck should move, but they're going to have little to no experience in treating the neck as it relates to headaches and migraines. So just know that you going to see a physio probably won't yield the result that I'm talking about. And I'm not trying to be I'm not trying to paint a bleak picture or hopeless, but I'm trying to be accurate, because if someone takes what I'm about to say and then just is like, oh, I need a physio, it's going to look very different than what we do. But anyway, so what happens is it's a movement problem. And our healthcare system, anyone with like an MD or MBBS behind their name, anyone with that training is not necessarily going to be understanding how to look at the neck from a movement perspective. And so it's all going to be still image, rely on imaging, X-ray, MRI, CT, things like that. And so we get some detail, but we miss the full picture. It's kind of like trying to diagnose like how a runner or a sprinter could improve by just like taking a snapshot.
Jono, sorry, I've got to interrupt for a second, because there's a story that a colleague of mine told me about. Are you familiar with Serge Grakovetsky? You come across him?
No.
He wrote a book called The Spinal Engine. He was a mathematician, and he used mathematics to kind of map the human body and the spine and how the body moves. His work was absolutely fascinating. I was lucky enough many years ago to sit next to him at a lunch during a conference.
Oh, that's amazing.
But he was at a conference. I think it was a medical conference, and it was mainly medical doctors in the audience. There was, I don't know how many were there. Hundreds of people in the audience, and he put an image up of I think it was a spine. Yeah, it was a spine, and he said, "Right, okay, who can tell me what's wrong with this spine?" And there was quite a lot of, "Oh, I'm not sure." Then one guy put his hand up. "Oh, I think I can see a little bit of ossification just below L3. And he's like, "No, that's not it." And another one said, "Oh, I think there might be a bit of a disc bulge between L4 and L5. No, it's not that." Another one puts its hand, oh, it might be a little bit of inflammation around the facet joints between, L5, S1. No, it's not that. Do you want to know what's wrong? It's a cadaver, right? His
Oh
point
gosh.
was, what can you tell about a living organism from an X-ray? I mean, yes, obviously you can tell if a bone is broken, but
Yeah, yeah, yeah.
it doesn't give you the full picture, right?
Yeah. Like the
So
most important piece of information was missed.
yeah.
Yeah.
Sorry, I interrupted you.
No,
Carry
that's
on.
funny.
I was,
I have a similar story from my time at Mayo. They did these grand rounds, and one of the orthopedic docs got up there, put an image on the screen, and asked the same question: "What's wrong with this image?" And same type of thing, but they said like the question that was asked was, "What's wrong with this image?" and what would the clinical picture of this patient be? And it was like herniated disc, degenerative disc disease, stenosis, like all these different things, and all like basically the room of very smart people said like this person is probably dealing with severe back pain down the right side, like numbness, tingling, has a hard time walking. And then the doctor goes, the presenter says, "Well, this is my back, and I have no pain." So anyway, relying on imaging is not it should not be the gold standard when we're looking at musculoskeletal conditions. And so, but it is basically the only thing that our healthcare system or a system is using. And if they do any sort of physical exam, they're just going to ask you like turn your neck. And the body's so good at compensating that that's also not a reliable way to evaluate. Like we need to understand the specifics of movement. We need to understand. So I've had people, and it happens all the time, that have had decades worth of headaches and migraines, and all they do when they come in, it takes about 5 minutes, or not all they do, but one of the main components that's like eye-opening for them is to lay on the table, and I literally just press, like put a little pressure on the upper part of their neck, and it'll be really sensitive, and oftentimes it'll shoot pain into their head. And they'll say like, "Wow, no one's ever pressed on that spot, but clearly it's reproducing my headache." And it's just like, well, yeah, that's the problem. Like that's the issue. And they've been to Mayo Clinic, Johns Hopkins, they've traveled around the country, they've, tried all the medications. It's like this is the most complicated thing our healthcare system has ever seen, but no one's touched their neck. Like literally no one. So anyways, that's the problem. Like that is the issue. I see it all the time. And so that dynamic leads to the world of medication that we see, as opposed to understanding like a root cause approach to care. And so when it comes to addressing these things, yeah, it doesn't take a lot to diagnose, just because a physical exam and understanding what movement in the neck should look like, and move. When I say movement in the neck, so we have two bones, the C1 and C2, or atlas and the axis. The atlas is going to basically cup our head, the base of the skull. It allows for nodding, a little bit of side bending. And then the axis is a thumb-like structure, and it sits just below the atlas, and it allows the neck to do rotation. It does about 45 degrees, so about half of your full neck rotation. And we typically find that both of those are pretty restricted. Like there's not a lot of movement there. And so one of the differences, so you mentioned NUCA chiropractic. So, yeah, NUCA is focused on that area as well. They would take more of an alignment approach, whereas we take more of a mobility approach. So we're using hands-on techniques to restore function. It's not that we don't care about alignment, but we would just take the approach of once we get things moving, that's more, in a sense, like alignment will follow once the body understands how it can move again, and you're not increasing amount of stress just to try to compensate to get these movements done. Once we free up joint mobility, then the pain will reduce. And so that's kind of the idea, is like specifically the upper part of the neck does a lot of movement. It's overlooked because we're using still images. And once we find it and correct it, like these very complicated scenarios start to get much simpler to understand.
What techniques do you use to increase the mobility in the neck?
Yeah, so most of what we do is probably going to source back to a guy by the name of Maitland, who think he came out of Australia, but a lot of them are joint mobilization. So we're really just applying, there's different grades of joint mobilizations, but we're taking the joint up to tissue tension, meaning like we feel the barrier of how far that it feels like it wants to go, and then we push it past that because we know it can do that. And so think of it like, I tell people to think of it like, you hold your phone up to your ear, and after 15 minutes, you realize you got to straighten your elbow. And the whole idea is your elbow wants to move. And when you hold it in a static position, it starts to get achy. And so think of that over time. So if you didn't actually extend your elbow and you just kept it in that flex position over years, you would have an adaptation of the tissues around it. So like the ligaments that surround that joint would adaptively shorten, and every tissue in our body is adapting to the stresses or the lack thereof. And so basically, when we have an injury or a sedentary lifestyle or the stress that's built up in our neck, it'll guard. And over time, it just doesn't want to move the way it should. And so we just apply specific pressure to these segments with our hands through the joint mobilizations. And we repeat that. So it usually takes, we're seeing people twice a week for a couple months in order to get their neck to actually start moving again. And then we have a device that we sell for people that can't come see us in person, but it's just a specific pressure to the upper neck that's focused on movement.
So is it like a manipulation?
If by manipulation you mean like quick adjustment with popping or cavitation, we do that sometimes, but it's not our primary thing. So it's low grade. So a manipulation with the cavitation would be like a grade 5. We're usually in the grade 3, 4. So we're taking the tissue up to tension and then pushing it past. Whereas a grade 5 is more of that high velocity, like the really quick snapping, popping techniques.
Mm. Yeah, because Nuka's kind of, it's very low intensity but long duration, isn't it?
Yep. So they would be more in line with our approach, as opposed to like if you compare it to a traditional, if I can call them traditional chiropractic adjustments. Yeah.
Yeah. And once you've worked on the mobilization, do your patients and clients get exercises as well to try and maintain that range of motion?
Yeah, for sure. So we're looking at lifestyle changes. So the head is heavy. It weighs about 10 to 12 pounds. And so if you think about a bowling ball that you're carrying around throughout the day, if I gave you a bowling ball, you'd be shifting the weight throughout the day, because just holding it in one position, you'd fatigue. And then you also wouldn't want to hold it out in front of you because you'd fatigue even faster. And so we just want to look for things that are, for example, holding the bowling ball out in front for a long period of time, because your neck won't necessarily tell you that that's a problem until you just have a headache. So we look for lifestyle changes, but then we also incorporate exercises, whether that's for the neck or for the shoulders. The shoulders are closely integrated with the neck, and so we want to make sure the shoulders function well, they're stable, and then of course that you can maintain function in the neck and stability. And so there's a whole series of things that we look for and will educate people on as far as exercise.
Yeah. So I'm just thinking about the audience right now. They may be wondering, so how is it? What's the mechanism? How neck or jaw being, let's say, out of alignment, how would that cause a headache?
Right. So if we just assume that there's a problem, right? So whether you got there through trauma or through, like I use the cavity example, like your teeth are just in a state of stress, and then over time the enamel wears out. So think of the neck that way. Like little things, little stresses over time can lead to the same problem. So you don't have to have a known injury. So if we assume like, okay, there is a problem in that area, why does the head hurt? So the head hurts because the upper part of the neck, anywhere from the base of the skull to C3, is able to refer pain into the head. The reason it's able to do that is because it sends a pain signal through what's called the trigeminal cervical nucleus. This is a nucleus in the brainstem that picks up sensation from the trigeminal nerve, from the occipital nerve, and from the upper part of the neck. And so basically think of this as the nerves, these sensory nerves coming together, and they meet up in one spot in the brainstem. Then what happens is it sends that common signal through the thalamus and then eventually to the cortex. And then the brain is actually interpreting what is happening. And it has to interpret the location and the type of sensory input. And so basically, it's because of that neural pathway that it travels on and its overlap with facial sensation and back of head sensation that the brain gets the input. And it's like, okay, I have to figure out where you came from. And I'm kind of confused, but I know it's one of these three areas. And the thing with referred pain is the more intense it is, usually the more the brain's going to describe it to just everything, right? So an intense pain is like, maybe it was the neck, but because it's so intense, like everything's just going to hurt. That was coming from that pathway. And so when you're like, wow, it's a really bad, like eye stab pain, then we can basically assume like the neck is fair game to cause the eye to hurt. The things about referred pain, though, that we can use as like objective patterns, even though it's subjective, like the patterns can be trusted in a sense where if you have a right eye pain, typically it's a right neck issue. Or if you have a band-like presentation in your forehead, usually it's like tension built up through, multiple spots in the neck or shoulders, and it's usually muscle related. If you have an occipital burning pain, oftentimes it's like the nerve might be irritated, or there's like the OA joint or that first nodding joint can be irritated. So we see that the pain itself can't be trusted in like, if your eye hurts, you have an eye problem, but the patterns can be trusted in the sense of like, we can now get some information to know where to target as far as treatment.
Yeah. Yeah. So moving on, what role can stress, nervous system dysregulation, and a fear of pain play in keeping someone trapped in a persistent pain cycle?
Oh, yeah, significant. So I had a guy call me. He was in Canada, and he basically went through all of his symptoms, and they were bad enough where he thought something was being missed that was killing him, and no one had ever told him otherwise. And I didn't, I sort of there's difficulty in like diagnosing someone virtually, especially when they're out of the country. But I basically said like your presentation of pain clinically matches the people that we see all the time, and it's not something that's killing them. It's a neck problem. And I didn't do anything other than just explain how his body is responding appropriately, and it's likely not something that's killing him. And he said like the pain basically went away the next day. And so one of the things that our system does, Hippocratic Oath, like do no harm. Like I think I can argue that there's a lot of harm being done. And one of the ways that it's being done is, okay, you go to your provider and they do that image. Let's say, for example, that they find something in your brain, and it's maybe it's an abscess or a tumor or some sort of like small, like it's a finding that, everyone has a level of abnormality. And if we just like scanned everyone's bodies, like we'd all be terrified that we're dying to some extent. And so let's say you go in and you find something and it has nothing to do with your headache or migraine, and it's benign, and it has nothing, like it's not something that ever needs to be taken care of. But because it's an abnormal finding, what's going to happen is either your doctor or just you, based on the imaging, you're going to think like, okay, I am dying and it's this thing and it's a problem. And what's going to happen is your fear and anxiety around this problem is going to be elevated to the point where like it's way worse than it needs to be. And so thinking through our pain accurately, and especially as a feature, not a bug, and then trying to understand like what the underlying cause is super important, because if you start to extrapolate and build this idea in your head that it's way worse than it is, then I guarantee you it is going to be way worse than it is. And so perception of pain is huge. And I mean, one of the classic pain stories is, I think it was actually, maybe it was in Britain, somewhere in Europe. A gentleman, construction worker, had a nail shot through his foot, through his boot, and screaming in pain. Like they take him to the hospital. They can't even touch his foot because it's so painful. So they do an X-ray image, finally get the boot off. The nail didn't even touch his foot. Like it wasn't like skin was not broken. It went like in between his toes. But he perceived it as going through his foot. And so the pain was very real to him. And so we want to think about pain accurately. And as providers, we need to make sure we don't, paint some sort of image that makes it worse for that individual. So when it comes to the psychology of pain, it's hugely important. And then when we think about anxiety and stress, even stress outside of like your understanding of your scenario, I mean, stress puts our body in a fight or flight state. And then you're kind of on high alert. So everything's just like ramped up and more sensitive. And so when it comes to getting people into the parasympathetic side of things, we use things like different colored lenses, different light bulbs to try to calm people down. It could even potentially be different scents, although with migraines that can be a little risky because people are sensitive to those. We also use things like box breathing, or we look for something called over breathing, which is basically like how well is your body able to cope with CO2 buildup. And typically if you're super stressed out, you're just constantly trying to get your next breath in. And so we train people how to slow that down. And so things like that are super important so that just your general stress level comes down in order to tolerate pain.
Yeah, it's interesting, when you're talking about, someone might have a benign tumor and then, the medical professional assumes that's definitely the thing that's causing the pain, right? And, in my line of work, we know that there's so many studies have been done on, lumbar discs, for instance. And, it depends on the study, but could be anywhere from 35 to 76% of the adult population have bulging lumbar discs, but they don't have any pain.
Right.
But
exactly.
if you did MRIs of all those and showed them to a room of medical doctors, they would say, right, what's going on with these patients? And then they will go, oh yeah, they've probably got lower back pain, possibly sciatica. And like, no, there's nothing wrong with them. So it's very easy to make that assumption, to jump from, oh yes, I'm seeing something physical, therefore that must be the problem. The other thing that you mentioned as well reminds me of the work of Dr. Jono Taves. I don't know if you're familiar with him.
No. Yeah. Tell me about it. So
he passed away about 10 years ago, but he was kind of big in the 70s and 80s. And it's interesting because pain science is kind of, I wouldn't say caught up, but they've started to validate his general idea. There's certain things that he didn't quite get right, but his general idea was completely correct. Well, I say completely correct in some cases. So in his experience, which was, decades long and working with thousands of people, he suggested that people with chronic conditions were oftentimes suffering from repressed emotions that in his view, the conscious mind didn't want to allow the subconscious mind to bring it to the surface, either because it would be too traumatic or it would mean, letting out this rage, which is not acceptable in today's culture, right? You probably get locked up, right?
Right.
And what he was saying was the brain would create pain in an acceptable place in the body. When I say acceptable, it might be, for instance, lower back pain is very common. So it might be in the lower back, or it might be, someone does a lot of gardening, so they're always bent over. So, if you get it in the back, it'd be acceptable. If it was a runner, it might be in the knee, for instance. And it might be whatever's the fashionable, condition of the day. But his view was that the pain would distract the person from addressing their emotional trauma. Now, what's quite interesting, like reading his books and watching his videos, my feeling was his underlying understanding, I think, is correct. But there were certain things he was saying, I was like, I don't agree with those things. And what's interesting, like the modern pain science has come out and they've basically agreed with everything that I was thinking, was that his underlying theory was correct, but certain things about it wasn't quite right.
Sure.
But that doesn't mean to say that every chronic pain condition is caused by, repressed emotions, right? As I said earlier, it could be structural. I mean, if you've got, this is the thing I was trying to remember earlier. When you look at most people today, and it really depresses me, if I'm walking down the street, if I'm at the gym, almost everyone is looking down at their mobile phone.
Right.
You're walking through the park, everyone on a park bench looking at their mobile phone. So what's that going to do to their neck?
Yeah. So,
right?
Yeah, it's significant. I think, there's physical therapists on either side of this where it's like, oh, it's not a big deal. And other ones that are seeing it be a significant issue. I mean, if you just think about physics and the forces that are at play, I mean, your head weighs 10 to 12 pounds. So think of the bowling ball. Even with a 15-degree forward head posture, it doubles the perceived weight on your neck. And so, I mean, if you just had to choose, like, do I want my neck to hold up 10 to 12 pounds or do I want it to hold up 20 to 24? I mean, just like think 10 to 12, like that's better. It's less stress. And so like there's two types of stresses. There's bad stress and good stress. And our body in the absence of stress will deteriorate and decay. And so we need stress. The good type of stress are the things like exercise, putting our body in situations that it then builds and becomes more resilient. But something like stress of a neck being forward, looking at a phone for long periods of time is not the type of thing that's going to make the body more resilient. Now, over time, you'll adapt and become better at doing that. But that is also, it's dysfunctional in the sense like that's not how our body was designed to move. And therefore, it will lead to dysfunctional movement patterns when you try to do other things, or there's just going to be stress that builds up over time. And so do I think that all headaches and migraines are connected to like phone issues? No. But is it something that I would consider? Absolutely. And not only the neck, but also we have the impact on our visual system. And so the eyes have to look down and in. We're also seeing screens from an optometry perspective limit the amount of blinking and hydration of the eye that's happening. And so there's this dry eye effect where like the actual like tear duct will stop functioning. And like there's kids that can't even cry because their tear duct wasn't functioning with their blink to like hydrate their eye enough because they're just staring at screens. And so not only is it a neck issue, but we have like the eye looking down and in, which can cause this little tiny muscle called the superior oblique to get irritated. And so a lot of people with headaches will press there because that's a problem. And then there's also just the actual optometry perspective of the eye ball. And so there's all sorts of things that play into that. But yeah, staring at screens not good.
Yeah. I mean, years ago, I'm old enough to remember when I used to commute into London for work, and you're on the what you'd call the subway, and everyone that's sitting will be sitting there with a newspaper, right? So they were still looking down, but just not as much. They were not as much of an angle, and they're not necessarily looking inwards all the time because you're looking across. And if you were standing up, there wasn't room to read a newspaper anyway. But today, there's room to be staring at your phone. But it's not just phones, is it? Like you said, there's other screens, and most people don't set their computer up very well, so they're always looking down.
Right.
If anyone's around people that are shorter than them, they're probably looking down all the time. And, one of the things about, particularly the muscles on the lower part of the neck as you're looking down, they're lengthening, right? Well, that's putting quite an eccentric load through those muscles. And we know that doing that over a long period of time can lead to trigger points.
Right.
Right?
Right.
And trigger points in the neck can cause
headaches,
right? And, that one of the things that I love about the check system is the fact that we do very detailed physical assessments.
Yeah.
We do, Paul checks invented a specialized tool to measure the position of the head. It's a patented product, and it's the only one that I'm aware of that can actually measure the position of the head. And in the 25 years I've been doing these assessments, I'm seeing an increase in the amount of forward head posture in people. Luckily, mine's going the other way. Mine was terrible 25 years ago, and it's a lot better now than it was, but it's still not perfect, right? Because, living in the modern world, it's quite difficult to not look down, right?
Right.
Especially, I do read a lot as well. And, that's when I tend to do most of my looking down. I tend not to use my phone much at all. But yeah, it's definitely worth considering that there are multiple potential causes of headaches, like you were saying. You're not just going to look for that one thing that's going to solve the problem. And I think, sadly, a lot of people, whether it's headaches or other pain conditions or any other condition, they're looking for that one magic bullet. And my experience is, with any chronic condition, it's normally a combination of, a number of things, and definitely, reducing the overall load, what we'd call physiological load or allostatic load on the body, getting the body more parasympathetic, allowing it to rest and recover, really improve that pain sensitivity. And, to do that, you've got to look at it from a holistic perspective.
Right. Absolutely.
So I've got one final question for you. If someone's listening and they've, pretty much accepted that headaches or migraines will always control their life, what practical steps could they take today to begin addressing the underlying causes and moving towards recovery?
Yeah, it's so there's definitely a different degree. So sometimes people will listen to my podcast, the Headache Doctor podcast, because we're obviously talking about headaches and practical things to do, and they will put into practice what we talk about, and they'll find the relief that they're looking for. And then there's others that will put the things into practice, but it's not enough to get their situation to change substantially, and that's why we exist and providing the care that we do. And so I'm putting that caveat on there because how I like to make decisions is not necessarily like, okay, if you try something that is just generally improving your overall health and you're improving mobility or you're improving your diet and it doesn't seem to yield the results you were expecting, don't use that as like, okay, I can be critical of that and that wasn't working. What we tell people to do is move forward in a direction of general healthiness, and don't necessarily validate it based on your relief, because these are complicated things, and sometimes you might have hope that like changing one thing will yield a good result, but if it doesn't, that doesn't mean that thing wasn't helpful for your overall condition. And so I tell people to get time on your side. And you get time on your side by looking at those 3 buckets in the framework and trying to implement things in your own life that will improve each bucket. So for an example on each, if it's, okay, I want to cater to my neck. Well, it's like, okay, let's have a standing desk. Let's do things like chin tucks throughout the day to try to like get our neck moving. Let's go on walks frequently. Let's try to incorporate an exercise program. So give your body the movement throughout the day that it needs. If you're like, okay, maybe I have an airway issue, some simple things you could do is wear like a nasal strip or like a breathe right strip to try to open up your nasal passage. Mouth taping can be a helpful thing. Get your sleeping position right. Get a pillow that's supportive, things like that. If it's, okay, my general health seems to be an issue, well, look for things that are generally not healthy in your diet. Maybe you find yourself craving sugar, or you have an addiction to soda or something like that. Maybe you need to work with a functional provider and actually get to the core of like your gut microbiome and how you can correct it. And so there's different levers that people can pull, but I would encourage anyone to just think of your own health journey in your life and look at the physical, look at how you're sleeping, look at your overall health, and like make decisions to move forward in those directions. And then just know that if you still feel stuck, of course you can reach out to us at Novera Headache Center. We do a virtual and then in-person options for people, just because we want to help you either get granular with your own situation and providers that you might be able to find locally, or like actually help you solve the underlying neck issue, because some people just have their necks are just so tight and irritated that even if they implement things like standing desks and movement throughout the day, it's not enough to move the needle, and that's where we want to assist.
Yeah, absolutely. I've got one more question for you.
Okay.
I lied.
Yeah, that's okay.
I think I know what you're going to say, but I just want to hear you say it. Sometimes things like Botox injections, I know, are used for headaches.
Yeah.
What's your view on that?
Yeah, I love them. I'm just kidding. Yeah. So Botox, so we talked about symptom management and how pain is a feature, not a bug. And so like, if you just try to shut off pain, it ultimately leads to more issues. And so Botox, although probably one of the most effective forms of, quote unquote treatment, it's literally injecting a toxin into muscle tissue. And so what it does, it prevents the myosin from binding to the actin. So like the components of the muscle that allow it to contract are not able to do that thing. And so you're just like basically paralyzing a muscle tissue, and enough of this stuff will kill you. It's very toxic. And so
it's botulism toxin.
Botulism. Yeah. And so, they just like, I don't know, marketing, advertising, they make it like, oh yeah, it's just like reducing your wrinkles. So it's really, so think of the neck as dysfunctional. And so when the neck is dysfunctional, there's these trigger points that develop. So the muscles get angry and then they refer pain into the head, right? And so Botox is a very simplified way of like not solving that problem, but like treating it, because you're basically taking a muscle that's angry because it's having to do a lot more work than it wants to, and then you're shutting it off. Okay. So like that muscle in your neck was having to do a lot of work to hold your head up, and then you shut it off. So what happens? Well, what happens is not that your head gets lighter or your neck starts moving better, or that the problem's solved. What happens is all of that stress is still there. It's just transferred to something else. And so what we see when people get Botox over the course of like, a year plus, multiple years, is that their necks get very stubborn and very hard to treat, because they just keep eliminating the muscle that's trying to help the body function, and they shut it off. And then the stress just gets translated. Usually it's to joints, to other muscles, to the first rib, and they just present with very, very stubborn necks. And so even if there's short-term relief, what I tell people with any sort of medication and Botox as well is like medication or Botox needs to heavily be evaluated based on, if you are so debilitated you can't operate, but medication allows you to operate, then in the short term, there's probably a window where I'm okay with it. But if we are not trying to address the underlying problem and we're seeing this as just like an ongoing thing, then that's an issue. And especially if Botox or meds stop losing their efficacy, like if they don't work anymore, like, do not convince yourself that they're doing something, because they're causing harm. They're making the situation harder for your body to get out of. And so there's a very short window of like the medication or the Botox is working that I might be okay with it. But otherwise, yeah, we need pain to understand what's happening.
Yeah, that's exactly what I thought you was going to say.
Yeah. Yeah, you got me pegged.
Yeah. Jonathan, this has been great. What's next for you?
Oh man, what's next for me? I am working on a book. It doesn't even have a title yet. We're working on editing it. But for me, it's just my ongoing weekly podcast on the Headache Doctor podcast. And then Novera Headache Center is my day job, where I help people with headaches and migraines. And so we're in Colorado. We have 2 locations, and so we have, like I said, we have people travel from all over. But yeah, it's that's what's next for me, is just continuing on my mission.
Awesome. And where can people find you online?
Yeah, so it's NoveraHeadacheCenter.com. So that's Novera HeadacheCenter.com. And then the Headache Doctor podcast, like there's a TikTok that you can find me on, the Headache Doctor podcast. On Instagram, it's Novera Headache Center, or my name, Dr. Jono Taves. And so those are the different avenues that you can interact with me.
Awesome. Jono, thank you for your time today. I've really enjoyed it. It's been really great chatting with you.
Yeah, likewise. Thanks, Leigh.
Awesome. So that's it from Jono and me for today's episode. But be sure to tune in, same time, same place, next week on Beyond the Pain. Thanks for listening to Beyond the Pain. If this episode resonated, please follow the show, leave a review, or share it with someone you know who's been struggling. And remember, pain is not permanent. With the right insight and support, you can turn it into power. Until next time, stay open, stay strong, and keep moving beyond the pain.